Good afternoon, everyone, and welcome to the Support Hospital Opioid Use Disorder Treatment Shout Texas Echo. Please note that we are recording these sessions for later distribution. Know that your names do not appear on the recording of the session, nor does anything listed in the chat. Thank you all for joining us today. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick announcements before we begin. To help us with attendance, please enter your name, affiliation, and email into the chat function to help us with record keeping. We appreciate your support in helping us fully capture this record. We love to see everyone's smiling faces, so if you're comfortable and able, we encourage you to join by video, especially for the discussion portion of our session. We invite everyone to speak, but ask that you stay muted unless you're speaking. To mute and unmute, select the microphone icon on the bottom left of your screen if you've joined on a computer. Or if you joined by phone, use *6. You can also communicate with the chat feature to raise questions and share comments. Please note that no protected health information is allowed in either the chat or our discussions. During and after the session, the Shout Texas Echo team will send out a link to an evaluation of the session. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. So please go ahead and participate. Our didactic today is on social work best practices for homeless patients experiencing substance use disorder. Following that, we will discuss a case presented by Dr. Dustin Demos. We will start with introductions, followed by didactics, announcements, the case presentation, and open discussion. Thank you again for joining us at today's Echo. In the spirit of all teach, all learn, we encourage you all to share your experiences, questions, and insight in today's conversation. With that, we'll do some introductions. Dr. Ramesh?
Hi, everyone. I'm Dr. Jan Ramesh. I'm from Del Seaton Medical Center. I'm a hospitalist.
Thank you. Dr. Lindsay?
Adrienne Lindsay, Director of the Center for Substance Use Training and Telementoring at UT Health in Beeville, Texas. Thanks.
Thank you so much. Dr. Demos?
Hi, Dustin Amos. I'm the Program Director for a Psychiatry Residency Program at JPS and the Vice Chair of Education in the Department of Psychiatry at JPS.
Thank you so much for joining us. We'll go around. It's a small group today. So, Krista? Krista, would you?
Hi, yes, I'm sorry. Hi, I'm Krista Frederick. I'm the Senior Community Outreach Coordinator for the Telementoring Institute.
Thank you. Brandon?
Hi, I'm Brandon Strauss with Recovery ATX. I've been a recovery coach for about 2 months now. So, hi.
Thank you. Bobby? Bobby, are you able to unmute yourself? I think we'll come back. Jen? Yes, there you go.
I'm so sorry.
Go ahead, yes. Please introduce yourself.
Okay. I am Jen Biddle. I work for Community Care in Austin and am an LCSW addiction recovery therapist, primarily working with those experiencing homelessness.
Thank you so much. Cameron? Cameron, are you able to unmute? There you go. Yes.
Yes. Cameron Dale from Be Well, Texas. I'm the Senior Project Coordinator here, so I'm excited to be here.
Thank you so much. Ali Cole?
Hi, good afternoon. My name is Ali Cole. I'm an LCDC for Tropical Texas Behavioral Health, and I'm also the OSA Priority Admissions Counselor, which specifically works with clients for with opiate use disorder.
Thank you. Paul Salina?
Hey, my name is Paul Salinas. I'm a project coordinator here with the Recovery Services team with the Be Well, Texas. Excited to be here.
Thank you. Cody Andrews.
Hi there, my name is Cody Andrews. I'm an LCSW and a clinical case manager at the Downtown Austin Community Court. So I work with people experiencing homelessness. And hi, Jen. We worked together at the ER at one point. So thank you.
Thank you. Lauren Dreyer. Lauren, are you able to unmute and introduce yourself?
Hey, I'm trying. My screen is like not moving. So let's see. There we go. Hi, I'm Lauren Dreyer. I am a practice manager with Oak Springs Clinic with Integral Care. And we're a clinic that serves primarily individuals experiencing homelessness or with a history of homelessness, but adult mental health.
Thank you so much. Bobby?
Hi, my name is Bobby. I work with community care in the MAT clinic for medication assisted therapy.
Thank you. Patrick?
Hi there, I'm Patrick, and I work with Bobby at Community Care in the Medication Assisted Treatment Program as a counselor.
Thank you so much. And Maddie Escamilla?
Hi everyone, I'm Maddie. I'm a behavioral health PA at JPS Hospital, also the clinical champion of the SHOUT program up here.
Thank you so much. And Alana Bolton?
Hi there, everyone. Good afternoon. Thanks so much for joining. My name is Alana Bolton. I'm a program manager at Dell Medical School at the University of Texas at Austin and the director of SHOUT Texas.
All right, thank you so much. And I guess we'll move on to our didactic presentation right now. Jen, whenever you're ready, you can just share your presentation. You're okay. Please, can you unmute yourself? There you go.
Okay.
Yes.
You can hear me and see slides, correct?
Oh, we can hear you, but we cannot see your slides. So can you please share them again?
Yeah, hold on. I thought I had done that, but share screen.
Perfect.
Can everybody
Thank
see them now? Okay.
Please take over.
So
Thanks.
this presentation is on homelessness and substance abuse disorder in the hospital setting. I was told that there would probably be medical providers as well as some hospital and community social workers in the audience. So my goals are just to share what the issues are between homelessness and SUD and how medical providers and social workers can help this population. In the United States, we've got about 580,000 homeless people. It increases annually. And so there's a couple ways that are used to gauge the size of the homeless population. One is through a database called HMIS, Homeless Systems Information Systems. I'm not saying that right, but basically, if you walk into any organization or shelter, they will track, if you're a homeless person using their services, they will track you and just count that you have entered their building and you are using so-and-so service. And so that's one way to get a good number of how many homeless are served. Another way is the point and count. process that happens usually every January. Volunteers, groups of volunteers will get together and go out in hospitals and shelters and encampments under bridges and actually physically count the number of people. And so that is that. And a lot of y'all know this, but the relationship between homelessness and SUD is sometimes homelessness causes substance abuse, sometimes substance use causes homelessness. And without having a very secure social support system, even if you're not homeless, it's really difficult to recover. So it's even more difficult for folks that don't have any support system. I'll let y'all read through this a little bit, but I'm sure everybody knows about back in the 1980s, there were just the history of the crack or rock cocaine versus powder cocaine and getting caught by the police. If you had 5 grams of crack cocaine, you would do up to 5 years in prison. And if you had 500 grams of powder cocaine, you would do the same time. Things are getting better. President Biden, it's on his agenda. So we're very excited that that is happening and that harm reduction is becoming bigger nationwide. This is just a chart from the Boston Healthcare for the Homeless program, just to show that opioids were the biggest cause of death by overdose from 2004 to 2018, then cocaine, then psychostimulants, which are cocaine and amphetamine-like substances, and then benzodiazepines. And this is just another, documentation from the JAMA Network Open, just that states that most people that have experienced substance abuse have at some point experienced homelessness. This is a very detailed list of different substances that the homeless use. I've broken it down into the first sentence as why people use that certain substance, what it does for them personally. So I'll let y'all read that. One thing that's interesting is people that are homeless, especially women, will use methamphetamine so they can stay awake at night, stay away from assaults and robberies, and stay alert and protect themselves. I'm going to ask a question. I don't know if y'all will be able to answer it or if y'all can just chat the answer. But does anybody know what a speedball is? It's kind of a trick question. And then does anybody know why people would use speedballs? I'll go on to the next slide. And this is probably the biggest part of the presentation, just how to address homelessness and substance use disorder. Every community that is mid to large size usually has an FQHC or a community care light clinic. And so these are services that are in Austin, but are most likely all over Texas. We have something called the M3 team that is a collaboration between Integral Care and Community Care, and that Community Care has the medical provider on the team. They have a peer support specialist, substance use provider. It's a very well thought out program that is very wraparound in the way that it works. I am affiliated with the M3 team because I volunteered to do psychotherapy for anybody on the team, because there wasn't anybody providing that specifically. And in order to be a patient on the M3 team, you've got to be chronically homeless, have a complex medical issue or issues, have a substance abuse diagnosis, and have a mental health diagnosis. Texas Harm Reduction Alliance and different harm reduction places kind of operate under the radar, but they provide just invaluable services. I know one of ours in Austin has vans kind of spread out through the city, and they'll have on their website, like, we'll be behind this church from 1 to 4 on Mondays or something like that. Sobering centers are what they sound like. They're free to the community. Local EMS, we are very just grateful to have community health paramedics in Austin, and I'm assuming that a lot of larger cities and even smaller cities have this as well, where the paramedics actually go out into the community and work as caseworkers. We have a specific CHP or community health paramedic that can actually dose people on buprenorphine or Suboxone until they can get into treatment, like with the Mac Clinic or into a different OBOT treatment or something like that. OSAR it's very important, it's very needed, but it's got some holes in it that we have to work around. It is basically a number that you call if you're needing treatment for substance abuse, and they will set you up with an appointment for like next week. We're going to give you a call and we'll do the assessment over the phone. And then they call and they do the assessment, and they can provide financial assistance to people that don't have substance abuse disorder insurance or coverage, or if you have MAP, then of course you would be eligible for this. And then there's a wait time, and that's the critical time of waiting. And that's when, you know, a lot of us as social workers and therapists can come in for support until they get into treatment or detox to facilitate hope. Many times now in hospital emergency departments and inpatient units, medical providers will start patients on buprenorphine or Suboxone or equilibrium taper for those with AUD. And kind of coming back full circle, housing first, and why is it so important? A lot of folks don't really know about the model or understand why it's so important, but basically the belief is that you're going to go ahead and house homeless folks with issues like SUD and mental health before treating their condition. So they actually need some stability and just stability in where they're living before the illness can be treated. That's kind of the concept behind that. And then this question is seen from just an ER social worker, which I was for many years at Brackenridge. So sometimes we come up with a physician that comes to us and wants to discharge a homeless patient before, like, that is intoxicated before they go into withdrawal. So there's several things a social worker could do. They could ask the physician if he would consider equilibrium taper until that patient can get into detox or treatment. The social worker could have that patient transferred to the sobering center. This one is kind of iffy, but if you have a mental health diagnosis and you're acutely symptomatic, like SIHI, psychosis, severe depression, and intoxicated or have a substance abuse issue, you can either, the social worker can request funding to get you transferred to a treatment facility, or if you have private insurance, that can be used as well. And then you can go to one place and get your SUD and your mental health issues treated at the same time. If the homeless patient has no choice but to be discharged to the street, a social worker can help that patient create an aftercare plan. And I would like to ask if anybody has any ideas of what a good aftercare program would look like before that patient gets into detox or treatment. And these are just the key points. There's a clear connection between homelessness and SUD. We've got a lot of resources in our community. Sometimes we just need to dig and find out what they are. And then, of course, we want the providers to consider the magnitude of the issue at hand. And that is all of the presentation. So I'm going to stop sharing if that's okay. And does anybody have an answer for what a speedball is? So a speedball is when you mix an opioid with a stimulant, and it used to just be an opioid with cocaine, but now it can be an opioid and methamphetamine or a stimulant. People use them because it increases just the strength and the magnitude of each drug. And they're very dangerous. You should not use them, but a lot of people do that. And then can anybody think of what would make a good aftercare plan if you were working with a homeless individual that was fighting DTs and going into withdrawal, and they were going to be discharged from the hospital?
I think part of the aftercare would involve making sure they were aware of where PES is, possibly getting them connected to Narcan resources so that they have that on their person, or be able to distribute that to people that are maybe they camp with, so that there's an option if, unfortunately they do overdose when they're outside, and making sure that they have somewhere to go to use a phone or get connected to someone who can help them stay in contact with OSAR or the other detox facilities.
The answer. Anybody else?
I see a comment in the chat: medically safe detox and then treatment.
Yes, that is excellent. If they can't get into detox because they don't have insurance, what could they possibly do? The patient or the social worker with the patient.
Also just talking about a harm reduction plan. So you don't want them to necessarily stop cold turkey if it could be further harm to them. So how are they going to keep themselves safe but still work towards their plan and maybe gradually get to the next place? You don't want them to get into worse health than where they're at.
Does anybody, I'm sorry.
I was just going to say, I was kind of just thinking about a housing first approach, just more broadly, of making sure that they can get into some permanent housing, ideally rapidly, even if maybe they're, say, going to continue their alcohol use. I know that's easier said than done. There aren't necessarily housing first options in every community, but.
Right. Yeah. Does anybody have any questions about the presentation?
This is John here, one of the hub folks. Thanks, Jen. That was awesome. One other critical piece of the landscape I want to introduce is the idea of medical respite. So there's over 100 medical respite programs in the U.S. specifically designed for people experiencing homelessness who are too sick for the street but not sick enough for the hospital. There is a very early version of one here in Austin that's being funded by Central Health and run by Dr. Audrey Kwong. And this is for folks, it has a wide variety of utility. It can be for people who really need a colonoscopy, for instance. They just need a safe place to do the preparation for a necessary procedure. But we can also think about it within the continuum of our substance use disorder care, right? So somebody made a great point earlier, right? Like detox first and treatment. I really agree. You need to be at the right level of care to appropriately manage the detox syndrome itself and any associated medical complications. And then the respite can often be a place where that aftercare plan starts to take more shape. And when respite programs have been sort of evaluated, it is associated with increased engagement with housing resources and then SUD aftercare plans afterwards. And I'm not sure if there's folks from other cities in Texas who have any experience with either respites or sobering centers or other sort of novel approaches to serving people experiencing homelessness and how that fits into the care plans for situations like Jen described.
So John, here in Fort Worth, through our local mental health authority, county funded programs, we have, it's called a crisis respite unit, 28-day program where patients can go and continue almost like an aftercare where they can continue a step wise progression towards maintaining sobriety, getting some help with detox. Some of the barriers to that are their formulary. And so we'll have to, send them with a month's supply of the medicine straight from the hospital. So those are some of the challenges that we experience here, that they had to have medications in hand for all their challenges, HIV or whatever, that they have a month's supply in hand when they go to these programs. And I don't have to tell you, but some of the HIV medications are extremely cost prohibitive to continue, for a month's supply of this stuff. So we do have some of that, some of the respite stuff you're talking about, but it's, navigating the barriers are a challenge that we experience.
Thank you so much. This was an excellent presentation. Thank you so much, Jen. And we will now move on to some announcements. And before I do that, I do see a lot of new members who've joined this ECHO session. So please enter your name, affiliation, and in the chat so that we can maintain our records. Thank you. Be Well Texas is a welcoming environment with caring professionals who are ready to help people start or continue their journey towards recovery. Be Well Texas is committed to expanding equitable access to compassionate evidence-based treatment and care for SUD throughout Texas. Next slide, please. From now on, when you sign up for one of our Shout Echo sessions, you will automatically be included on all our Shout Echo sessions. Please remember that we have a separate Echo sign-in for each, a separate registration for each of our Echoes at Be Well Texas. So please make sure to register using the different links. Thank you. And next slide. The Be Well Texas Clinic offers high-quality treatment for addiction recovery at low, no-pay or self-pay insurance, so all patients are accepted regardless of their payment ability. Next slide. Our next Shout Echo is on May 19th. Please do join us. We have some exciting speakers lined up. Next slide. And we have some exciting news. We are starting a brand new harm reduction Echo. I think it's so pertinent for just what we just discussed right now. Please do join us. This will be held on the first Thursday of every month at 12 noon. Our inaugural session is on May 5th. So please join us, and we will be sharing the link in the chat, the registration link. Next slide. Heroes Helpline is available to all first responders and healthcare workers, including allied health providers in Texas. It's absolutely free and provides complete, confidential, telephone-based peer support and referral services. Thank you, Angela. We will now move on to our case presentation. Dr. Dimos, once EcoIT shares the screen, please walk us through your case.
Well, I just want to first thank all of you who have been such an instrumental part of getting our SHOP program up and running here in Fort Worth. This is a phenomenal organization that we stumbled on a little over a year ago now. And with the collaborative nature of these Echo series and this team, we've been able to do quite a bit of work here in Fort Worth. And I just want to set the context for a second. Prior to 2020, January 2020, JPS had 0 substance use services whatsoever. We're like probably most hospital systems. We admit a patient through our emergency department. We acutely stabilize them, and we try to get them out the door as quick as possible. But as we just heard, sometimes, depending on the patient population, it's more difficult than others to find that good receiving place to get them to. Respite units, detox programs, what have you. And so, once we got some semblance of an addiction service here in January 2020, it was in the form of a bridge clinic that we started with some grant funding in our psychiatric ER. And it was really, that clinic, and when we were awarded the Shout grant last year, those two efforts combined really, for lack of a better word, really set a fire under our healthcare clinicians, both in the ER and in our inpatient hospital as well. And with our pharmacy colleagues, I think hopefully Elise Ortega, she is going to be trying to jump on whatever she's kind of tied up at the moment, but she's going to be jumping on here in a little bit. With our pharmacy colleagues, we really went to bat on a lot of different fronts. We got buprenorphine on our formulary, which was great. Elise is here. She's just under my name. That's good. And so we got buprenorphine on our formulary. We're able to educate a lot of our inpatient folks as well as our ER colleagues on signs and symptoms of opiate withdrawal and how to initiate that medication safely in the emergency setting and in our inpatient setting. And so one of the our case today is, how do you take where you are and try to advance that? And so in order to give buprenorphine on our formulary to begin with, since we didn't have a whole lot of people who were very familiar with the medication and didn't know how to safely administer and dose in a safe fashion, we worked with our pharmacy colleagues. And one of the things that we were able to negotiate was, well, let's only allow people to prescribe it who are safe in doing so. That's our ex-waivered folks. Those are folks who are educated in our emergency setting, both our medical ER and our psychiatric ER. And so those are the three restrictions that we placed on ourselves in order to get the medication on our formulary. And so because at the time, it was our bridge clinic that was the mainstay of our substance use treatment. And once we got the medication on formulary for our inpatient, and with the help of the Shout team, we were able to then roll out some of the education so we can fill in some of those knowledge gaps for our inpatient providers. And then ideally, later on, start to remove some of those restrictions that we're experiencing. And that's where the crux of this case is today. We have educated over 450 clinicians at our hospital, which is a staggering number. We have a lot of people involved in that effort. Maddie Escamilla, who's on right now, was an integral part of that. And with help from Alana and Rich, who was previously with us at Dell, we had a great set of PowerPoint slides that were effective in our communication strategy as we rolled out this education effort. So one of the things that we, now we're sitting where we are, how can we reduce some of those restrictions that we implied on ourselves? And then also we, ran into some administrative and leadership challenges, in that effort at the same time. And then I'm gonna invite Elise Ortega, Dr. Ortega, to give us a little bit of an insight from a pharmacy perspective on, what is the concern for any kind of audits that may be, impending from the DEA. So Elise, can you fill us in on some of the last point, I guess, in terms of the audit concerns?
Sure, I'll do my best. Hello, everyone. I'm Elise Ortega. I'm the Director of Clinical Pharmacy Services here. I am co-chair of the JPS P&T committee, so that's the reason Dr. DeMoss invited me today. I have colleagues in the operations side, and so there is a definite struggle with our retail pharmacies having concerns over filling controlled substance #1 here at JPS, but then also having so much information that they're receiving about filling specifically buprenorphine or Suboxone prescriptions. They feel like they are being held out individually and being scrutinized by the DEA for filling the volume of prescriptions that JPS fills. And so they are at risk, or they feel like they're at risk of losing their license. And so that is a huge concern for anyone to lose their individual licenses. They also are very concerned about how JPS put this program into place. They feel like that they don't have visibility to a lot of different key components that they feel like that they need. Currently, they tell me that they're getting prescriptions for pain medications as well as Suboxone at the same time, written by the same provider. They're getting prescriptions for very, very high quantities of Suboxone with 6 refills. They're getting prescriptions from providers that they're not able to verify that they have X waivers. They're getting prescriptions from providers that seem to be exceeding their limit in the number of patients that they should be treating. And so they have asked if we could possibly kind of coordinate some of these information items with the JPS providers and look at the whole program and try to get more visibility to them so that they feel more comfortable in filling these prescriptions. Dr. DeMoss, does that help?
It does indeed, Elise. Thank you so much. And so it sounds like more outpatient kind of coordination is some of the challenges that we're some of the concerns that the pharmacy is having in terms of our buprenorphine program currently. Is that accurate, or?
That's the operations side of it. In addition, like you mentioned before, there's definitely a financial piece. Unfortunately, several of the grants we thought we're going to have funding for it, but to this point, we haven't had any funding for it. And so it is an expensive, costly program, not so much for the buprenorphine inpatient, but for continuing the therapy outpatient when a patient doesn't have any funding source or not able to pay for the medications.
Fantastic. Thank you, Elise. I can't thank you enough for joining us and giving us a real clear picture on some of the challenges that we have here locally but also I'm sure our audience, depending on where they are in the stage of their, of their rollout, these are some barriers and some hurdles that they can anticipate and hopefully address before, launching a huge effort like we have here. So, thank you again. I wanted to touch on another thing that, let's see. Oh, the administrative and leadership kind of hesitancies. This is not including pharmacy from the C-suite, so to speak. I think Rich used the term the Nimby attitude. Not in my backyard is what Nimby stands for, and that is the perception of some folks in the executive suite who may think that, hey, our hospital is built on, seeing a certain kind of patient. We do a lot of heart caths, or we may be more procedure oriented, or may have a different population that we don't really want to be, seen in the same waiting room as some folks with substance use disorders. And he gives a great example of one in particular meeting that he was in when somebody said, yes, I believe in this effort, but maybe not here. And so I think that could be also contributing to some barriers folks that are trying to roll out some of this effort that they may be experiencing as well. And then let's see. Thank you. So the overcoming the barrier, and in addition to addressing some of the things that Dr. Ortega has just mentioned, costs, kind of some prescribing habits, and providing potentially some further coordination with some of those outpatient providers. Another thing is trying to expand the X-waiver training, because that's a great way for, number one, to increase the individual clinician's education and knowledge about buprenorphine. But also, second piece is with our most recent change in the X-waiver process. Once you have the X-waiver, you can apply to increase your number from 30 one-month prescriptions to 100 one-month prescriptions. And so that can address one of the challenges that Elise just mentioned, potentially prescribing more than your allotted number. And then I think, Alana, correct me if I'm wrong, I think there was an announcement at the Texas Substance Use Symposium that maybe Be Well or another organization is going to be launching an effort to provide X-waiver training to a lot of different sites around Texas, or am I making that up?
I can speak to that. This is Adrienne Lindsay. Yes, so we've been piloting a new process actually here at UT with our emergency medicine department to do kind of what we're calling a brief bup waiver training, not too dissimilar to what getwaivered.org is doing nationally with their 8-minute waiver trainings. So essentially they'll be fully virtual. We'll take about 10 minutes to walk people through the notice of intent to prescribe. And then if they can stay on another 50 minutes, the rest of the hour will be kind of a didactic about induction and things like that. But ultimately, we'll walk people through the process in real time to try to at least help them go through that NOI process. So we just wrapped up those pilots with UT Emergency Medicine, and then we'll be rolling out statewide. So we'll be sure to share through the ECHO network, so everyone will get the information about the first one. And those will be entirely free, of course.
Fantastic, thank you, Adrienne. And so I guess to summarize, one of the challenges we're experiencing more on an inpatient basis are the restrictions that were in place as part of our pharmacy and therapeutic P&T application. We're working to address some of those things that we can address inpatient. And we're working closely with our outpatient colleagues, family medicine specifically, because we have a very, very large family medicine presence here, to not only expand some of the X-waiver trainings for the attendings and residents, but also to make sure that we're in compliance with not only our X-waiver number, but also in the prescribing habits, addressing the concern that Elise raised, using full agonist and partial agonist at the same time. So And one area that we have not been successful in is engaging our pain management colleagues. That's an area that we're going to be focusing in the next several months, getting them on board, getting their insights into how they practice and how we can, come together for a more coordinated effort, both inpatient pain management as well as outpatient pain management. So, and that's the majority of our case, and I'll be happy to take any questions. And again, I just want to thank Elise for Ortega for coming on and sharing some of those insights.
Thank you so much, Dr. Dimos. I just want to open up the floor to everybody. Dr. Ramesh, I think you had some thoughts about the case.
Yeah, thank you, Dustin, for bringing this case forward. It sounds like your group has done a lot of great work in educating so many clinicians about buprenorphine, and depending on where you're practicing in the outpatient setting or the inpatient setting, or even in the ED setting, there's different regulatory and legal considerations for prescribing and or dispensing buprenorphine. So it can be tricky to navigate these barriers and legal ramifications based on where you practice and where you normally treat patients. So I think with that, I wanted to kind of open it up and ask, because I know we are all from very different settings here and we practice in different settings. What are the main barriers that you all encounter and what you have done to work with your team members in overcoming the stigma and trying to increase access to buprenorphine for your patients?
Excuse me, I'll jump in really quickly and maybe just kind of point out one of the things that we struggled with when we were implementing our initial B-team program at Del Seton Medical Center, which is the model that Shout Texas was then built upon, is the distinction between ordering and administering buprenorphine in the hospital setting for a patient admitted for an acute medical need versus prescribing buprenorphine for outpatient use after discharge. And I think it's important to make that distinction. And then as Dr. Ramesh alluded to, there's also an additional distinction between providing buprenorphine for patients in the emergency department setting. So I don't know, Dr. Weems, would you mind kind of commenting on what the clinical distinction between those three items are and what the practical differences are?
Sure, absolutely. And Ilan, just to clarify, this is about prescribing versus administering.
Correct.
Okay, for a quick second. Yeah, it's really important. And for folks who work in the ER, you might have heard of the 72-hour, the 3-day rule, which is an important distinction, and it's an exception in what we can do to serve our patients with opioid use disorder, and the medication regulations, which state that methadone for the treatment of opioid use disorder needs to be prescribed in an OTP in the outpatient setting. And when patients are in the hospital for other reasons, continuing their MOUD is totally appropriate. And so methadone can be prescribed in that setting, and the formulation and the prescriber doesn't matter, whether it's buprenorphine in the inpatient setting. There's also the 72-hour rule. What the 72-hour rule states is basically an exception that you can administer, so not prescribe, but administer medications like methadone and buprenorphine to a patient without an X waiver and without being an OTP. And you give 1 day of meds at a time. And there's it's kind of an exception, and there's some great guidance from ACEP, the American College of Emergency Physicians, about how to roll this out, how to do quick starts for programs if folks are interested. That's available on the ACEP website. But that it's really important to say like that, you don't need an X waiver for that. It could be administered to the patient there. It's not the same as giving them 3 days worth. So you're not administering a pack of medicines to facilitate linkage to the outpatient treatment. You're administering the medicines there. And there's some really innovative examples of outpatient clinics, which have actually brought methadone online through this exact same regulatory sort of area. And BMC is kind of the national leader in that. So it's a place that's changing a lot, and a kind of a different way that MOUD is regulated with that 3-day rule. Does that answer your question, Alana?
Yeah, I think so. I think going back to one of the items that Elise, Dr. Ortega had mentioned, kind of as she was providing her perspective earlier was, and please correct me if I'm wrong, Dr. Ortega, was concerns about pharmacy departments not being able to verify or confirm that physicians who were ordering buprenorphine were currently ex-waivered. And I think the important distinction here is that to order and administer buprenorphine in the hospital setting for an admitted patient, those prescribers or those with prescribing privileges do not actually need to be ex-waivered for the administration of buprenorphine in the hospital setting. Is that correct?
That's exactly right. Yeah, that's exactly right. And I think Dr. Ortega brought up a lot of really important issues that come up for pharmacists who are left to deal with this like really onerous task of making sure that they're practicing within the scope of their license and that they're doing what's safe for the patient. And what we found here at Community Care is that it's really helpful to have an interprofessional team, including pharmacists. So we're really lucky here in Austin. Lucas Hill is a professor at the School of Pharmacy, and that he's often talked to our pharmacists here and then community pharmacists to address some of those concerns that come up around, hey, look, am I within scope here? Is the DEA going to look upon this with scrutiny? So it's really helpful to have an interprofessional team to engage that. And it sounds, Dr. like there's a couple of things there. There's administrative concerns about individual prescriber practices and those enforcement concerns. And it might be great like to have a group to sit down and sort of look at those individually and kind of take apart which problems have easy solutions. I can say as a prescriber, I would love to know about those, you know, like if there was questions about if a regimen I was recommending and had indeed prescribed for a patient, if those were safe and effective, I would definitely want to be a part of that conversation. So reaching back out to the clinician team, it's, you know, we're in healthcare and it's hard to get people on the phone, but I know I myself would love to be a part of that conversation. My guess is a lot of those folks who are prescribing would want to be a part of that too. And just tell them too about like Shout Texas and that, hey, look, if you have questions about scope of practice, if you have questions about best practices, there's a free state resource to talk to people about how things are going and if you could get some more support in their medical practice. So I think it sounds like there's a ton of opportunities there. It's great that the pharmacy teams and the medical teams, psychiatric teams are working together. And especially having the pharmacy team there is so huge.
Yeah, absolutely, John. I think I you know, echo your point on the prescribing piece. Like I would want to know if what I'm doing has the potential for adverse outcomes for the patients. And you know, Elise and I we're just messaging each other about how, you know, this is a good launching pad to find out what we have and figure out a way to address the things that we're identifying so we can bring it back to this group as a whole and, you know, help others avoid some of these, you know, potential pitfalls and, you know, develop procedures and flows beforehand to, you know, to avoid any potential adverse outcomes in patient care.
Thank you so much. This is a great discussion. Does anybody else have anything to add in the learning community in terms of if you've experienced any similar challenges?
It's Jim Detian. I'm at JPS with Dr. DeMoss, and just from the emergency, and I'm an emergency physician, from the emergency medicine standpoint, once we were able to overcome the barrier of one, community standard, so our ED prescribers could give 3 or 5 days, that was a huge help. The other was establishing a pathway for a referral that could pick the patient up within a short period of time. You know, Be Well Texas has a program now going on. We started a bridge program and then transitioning to the family medicine and other care pathways. Those are the biggest barriers that I found in implementing processes in the emergency department. Once those were done, I think our ED docs got on board really quickly.
Thank you. And any thoughts about how to approach leadership when such programs are being started, or how have you dealt with that? How do you get the buy-in?
I can jump in again.
was
I
that, Drew?
apologize. I feel like I've been talking too much on this session today, but from a Shout Texas perspective, when we are first meeting with, potential expansion sites or existing expansion sites, especially as we're talking with leaders who have multiple concerns, they've from a clinical level, from an administrative perspective, from a budget perspective, like their concerns are so comprehensive. I think the two main points that we always try to drive home is that ordering and administering medications for opioid use disorder for an admitted hospital patient is like good patient care. It saves lives, it improves the patient experience. And like, this is the take home piece right here. It's absolutely legal. It's included in accepted authorized practice of medicine for hospitals, as long as that patient is hospitalized for an issue other than an opioid use disorder. And I think that goes back to a lot of what we've talked about as far as just stigma and misconceptions and misperceptions and misinformation or misunderstandings that are out there around administering medications for opioid use disorder in all settings, but for the purposes of this conversation in the hospital setting. So to all of our learning community, as you're talking with your leaders, I mean, that's the drive home point. That's the take home point, right? That this is standard of care, it's safe and effective, and it's legal. And then, you absolutely can trickle down into the minutia of that, but that's the take home piece. I actually do have like the regulation pulled up that I can copy and paste in the chat. It's really long and not really very fun to look at, but if anyone's interested in that, I can send that out as well after the session.
Thank you, Alana. Jim, I believe you had something to add.
No, I wasn't sure whether you were addressing that question to me. Thanks, Alana, for stepping in and answering it.
All right, Doctor, we're almost at the end of the hour. Dr. Ramesh, would you perhaps summarize some of the key points that we spoke about today?
Sure. So thank you all again for coming to today's ECHO session. Thank you, Dustin, for posing this question about the main barriers that people encounter when prescribing and dispensing buprenorphine in a variety of settings, whether it's ED, inpatient, or outpatient. So we had a good discussion on first, how to engage with your pharmacy colleagues, getting the medication onto formulary and the barriers that you may face with the outpatient pharmacists who are concerned about filling prescriptions and the legal ramifications of that. And the take home point from today is that prescribing buprenorphine for opioid use disorder, though you are required to have an X waiver to prescribe, you do not have to have an X waiver to dispense or the medication in an inpatient setting, and it is a standard of care and good practice to do so. It's legal and reduces overdose events and ED visits by patients. So really about creating a multidisciplinary team to make sure that pharmacists and providers and people in the ED are all kind of on the same page on providing good patient care. And then increasing X waiver training or even the notice of intent notification for as many providers as possible so they become comfortable with prescribing buprenorphine. And that's about all I had. Great work, everybody. It's really nice to hear about how much education is being put forward in so many different settings to make sure patients have access to great care. And as always, we have a great wealth of resources on Shout Texas and Be Well to continue.
Thank you so much, Dr. Ramesh. Thank you all for joining today's ECHO session. As a reminder, to earn CME and CNE credits, please complete the post-session survey using the link in the chat. We look forward to seeing you at our next session on Thursday, May 19th. Have a great rest of your day. Thank you.